Well, good morning, good afternoon, everyone. I'm glad that you're able to join us this morning or this afternoon to talk about what we've been doing with the International Consortium on Manual Therapies. So this concept was first developed from earlier meetings in this century, where in an interprofessional environment, there was a clear observation that when it comes to trying to understand what we're doing clinically within our professions, as well as between our professions, as we try to understand the research that's being done, we have a lot of challenges and issues that have evolved over the years. And it begins with as simple things as just the language we use to describe what we do with our hands. And we know that really our hands can only do three things. They can push, they can pull, and they can twist. And so just by the nature of what we do with our hands, we know that there's a lot of overlap that occurs within various professions that do manual therapies. And right now it is our language and our perceptions of what we do that keep us from really advancing this field into the 21st century. And so the goal that we have with ICMT is to break down the silos within the various professions within manual therapies for the primary purpose of it to help advance both the scientific understanding as well as the practice of each of our manual therapy disciplines. So for the past 2.5 years, it began in 2019, the summer of 2019, we began having meetings to develop our first conference for the ICMT. And we have been working with close to 30 people representing from the various 5 major professions. The osteopathic profession, physical therapy, chiropractic, massage therapy, and structural integration. And recently, from the work that we've done, we've been having discussion forums to give an update to our professions as to what we have put together during this time. And what we've put together involves primarily to make sure that we are describing what we do with our hands from various therapeutic techniques that we use, the understanding of the mechanisms for those techniques from a clinician's perspective in particular, and then learn from each other. Are the things we do, how similar, how different they are, even though we use a lot of the same labels, but how they actually get translated into practice can be unique or different. And so this morning, our goal is to give you just an overview of what we've been doing over the last couple of years in our work in preparation for the conference, where we begin to break down the silos, we open up communication, we develop better understanding about what we do and what other people do, so we can once again help to advance this field at a level that has not been done before. So first of all, are there any questions that anyone has about just the background associated with ICMT? Okay, so with that, I would like to go ahead and turn over the speaker for giving an overview on the scope of the work that we've been doing.
Do you want the mind map?
Yes.
Brian?
Yeah.
Okay.
Go ahead.
Sorry.
It's okay.
Going to share my screen now. Do you see the mind map now?
Yes.
Okay. So first, let's take a look at the whole manual therapy mind map. just to give you an idea of what we have been working on within the ICMT over the past 2 years. So all the techniques of all involved manual therapy professions are represented here. This is quite a lot of information we have here. So here we have the osteopathic profession, the chiropractic profession, the physical therapy profession, massage therapy, and also structural integration. So if we now have a look at our mind map of the osteopathic profession, so this is the mind map of the osteopathic profession alone. The first thing we see, I'm going to take a closer look, the first thing we see is division of the techniques into osseous, say, joint, and non-osseous structures. We realize that there may be some overlap, of course, and this might not be a very strict classification. And some of the techniques can in fact be found on both sides, such as, for instance, strain counter strain. We find it here on the osseous structure, so we can have tender points on the anterior cervical spine, for instance. And in the non-osseous structures, we can have also a tender point in the piriformis muscle, for instance. So, nevertheless, all manual therapy professions consider this classification in osseous and non-osseous as valid. The next division we see on both sides. So here we have the osteopathic profession, and the next division is the division in manual and instrument assisted. So we see that the main part of the techniques descriptions will, of course, deal with the techniques that are performed manually. But in all manual therapy professions, there are some techniques that are instrument assisted. As you can see in our profession, we have on both sides only one instrument assisted technique, that's the percussion hammer. Afterwards, we can see that the mind maps consists of 3 layers, 1, 2, and this is the 3rd layer. So the first layer is the names of the different techniques, such as, for example, an HVLA technique, and muscle energy, and articular technique. And on the other hand, we have also discovered some clinical models that rely on multiple single manual techniques, such as cranial here and cranial on both sides. We have also visceral, and we have also the fascial distortion model. We have been discussing this inconsistency because those are not single techniques, but a clinical model in our working group. And for the time being, we feel it is important that the profession has maximum agreement with the most commonly used terminology of techniques. Nevertheless, given our ICMT objectives, we cannot be satisfied with having to review clinical research articles, for instance, that state that the intervention consisted of doing some cranial, for instance. This is not really informative and certainly not specific. So we really want to move forward with this and propose some alternatives here within the conference itself. Maybe we can have some time to discuss this later after Leah's discussion of the cranial techniques template, for instance. Then the second layer, this one here, consists of the proposed mechanisms of action, such as intrinsic rebalancing of the ligaments with altering the proprioceptive and nociceptive input for the LAS and BLT techniques, for instance. And finally, the third layer consists of the different dimensions in which we work with these techniques. This layer that still needs a little bit of work and discussion, also with the ICMT Working Group 3, which deals with the measurement of physiological effects of manual therapies. So in this way, you have an overview of the mind map of the osteopathic profession. So please, Giacomo.
Yep.
So first, are there any questions that anybody might have about how that was laid out? The purpose, anything in regards to what was done with the mind map for clarity's sake? Okay, so, all right, Giacomo.
Hi, good evening or good morning or good whatever you are to everybody. It's evening here, I'm from Italy. So what I'm gonna show you now is another product. It's still in a very early alpha or not even beta phase. So I'm gonna share the screen with you. Here it is. So what we are trying to do here is, this is pretty much, as you can read from the name up here, it's a glossary. So it's a, or call it Rosetta Stone or how you want it. So we use both nominations here. What's really interesting here, it's pretty much a glossary on how we're used to recall about the osteopathic glossary, pretty much, for whoever of you is familiar with that, the glossary of osteopathic terminology written by the ECOP from the AACOM. Pretty much most of the terms in here that refer to our profession are taken by the osteopathic glossary. The very interesting thing is that also the other profession started filling it in. So what we have here is what term is used by the other profession as well by the osteopathic profession, for example, talking about us. It's really interesting to see. This is a nice way to start thinking what makes us different and what makes us similar in certain way. That is really easily accessible just looking at what terms is used in a single profession and what terms are used in more than one profession. For example, here we have the very first, which is accommodation. With this very definition is used only by osteopathic profession, rather than active assist movement with that very specific terminology is used by 3 of the other professions here. Not really from the osteopath, at least not looking at our glossary. In that way, we can start seeing, if we need to find a common language, it's really interesting to see the different flavors for different profession in naming different or the same word. That happens, for example, for the compression here. We have 2 compressions, one referring to somatic dysfunctions and one referring to a kind of treatment method used in different professions. So you can see here that the first kind of compression named here is used pretty much by osteopaths and physical therapists, while the second is shared between massage therapists and physical therapists, but not by osteopaths. Here it's interesting because once we start putting our heads on that, we might start understanding each other better, because what we mean for compression is not the very same that massage therapists refers to when they say compression. So being having knowledge of that will help us to understand each other better. Moreover, actually, we are trying, it's gonna, again, it's a very half phase right now, but what we aim to do is it's find a way to uniform the language. For example, a good idea for the next steps would be finding 2 different terms to describe 2 different things in order to align each profession on the meaning of the certain terms. that will make very much easier to understand each other when we speak. This thing is also here for the CRIP as well. So we have the very same word with two different definitions used in different professions with different aims. So the next phase after we will finish to fill it, it's kind of already well filled. There are hundreds of terms in here. We didn't take all the terms that were present in the glossary of osteopathic terminology. We are just trying to focus on what can be directly transferable to the palpatory findings, or, by the way, what we do with our hands, rather than conceptual frameworks like osteopathic models or definitions of something else, which is not directly palpable on a tissue, for example, or that is not a manually driven force whatsoever. So there are less terms because it's much more focused on the manual approach. So what we're trying to do here, next step might be starting to, we are already meeting up with other professions, but what we want to do next might be to start finding shared definition between different, among different professions for the very same term, if that term is used by that profession, otherwise it doesn't make sense. But if that term is used in two different professions with different meanings, a good idea will be to start finding different terms to describe different things. And finding a shared agreement between among different professions for that might be really great. The ending point of that, we were thinking, of course, there's also some media here. Let me find that. I can find it. Well, for some, like for the zinc model, I can find it written also. It should be on the. Can find it. But by the way, here it is. There's also the possibility to put diagrams in that in order to make it clearer. For example, for the fascial pattern, which I suppose is used from osteopaths and for structural integration as well. That's interesting because this kind of model were developed by, as you know, Gordon Zink. And so seeing that the very same concept is shared with another profession is quite interesting. So the ending point of this project would be to create a living document that might be continuously updated, and also with a system, I'm speaking without IT knowledge on that, but pretty much I think it's possible to open up the document to who subscribe to a certain website, for example, with credentials, and everybody collaborate in building a living document which can be continuously updated. That will really strengthen the profession, and will really make this document shared and you know, is not imposed for saying. So pretty much what we aim to do at the end of the day is this living document. Whoever got access to the document may put comments on that, and based on that comments, the working group updates the document. So this is where we are right now, and what we aim to do. We are again in a very embryonal part. It's really at the beginning, but and it's also from looking point of view, it's an Excel file right now. So we aim to do something much more beautiful. That's it. So I leave the speech to the next presenter. Well, if there's no question, of course.
Yeah. Are there any questions? So just to give a practical perspective here, people on this call were at a meeting in 2008 where we had basic scientists as well as interprofessional clinicians in manual therapy. And we had presenters from different groups given, and Paul Stanley, who's one of the originators of this consortium, stood up and he basically said to the clinician body in general, he goes, you know, I've been listening all day to what you've said, and I have no idea what you're doing, and I have no way that I could ever study it because I don't know what you're talking about. And when I listen what one group says versus another group says, it's clear you all don't know what you're talking about. And that was really, you know, kind of one of the nituses of this whole direction, is that we really have to have terms that are descriptive, that are potentially quantifiable, that can be actually used to help direct research in this field. And so developing this glossary, and Giacomo did a great job. It is intended to become a living document, just like the osteopathic glossary has been over the last 4 decades. But this is something, once again, for anyone who's placing their hands on the body, we should be able to talk about what is it that they feel and what is it that they are doing. It's not rocket science. It's not something that is unique from one group to another. It should be something that we have common language. So that's the purpose of this whole section.
Yeah, Brian, probably the further step next would be finding a shared language also with patients. I mean, I don't know if you ever tried to tell a patient that you have a cranial compression. First thing, they think they have a tumor in their head. Straightforward, you know, cranial compression. So we gotta be very aware of what we say with patients also.
Okay, so now we're going to begin looking at the individual descriptions of techniques that represent what we do as osteopathic clinicians with our hands.
So during this next part of the meeting, we're going to be going through 3 of the documents that we've created. And we want this to be as interactive as possible. So we have Google Documents where we kind of just break down specific osteopathic techniques and talk through what they are, what we think the mechanism of action is, what we're physically doing with our hands, and what we expect the outcomes to be on the body. Most of the material in these documents we kind of took from the ECOP teaching manual, because at least within the United States, that's pretty consistently what's taught in the osteopathic manipulation classes across med schools in the United States. But we have incorporated aspects from our European colleagues, because I will confess that as an American DO, I've learned a lot. G, would you be able to help me share? So the first one we're going to go through is muscle energy. Let me expand that so I could see people. And I also wanted to let everyone know that after this meeting, you'll all have access to these documents and an opportunity to comment, and all of that will be in real time. So you could say, well, what do you mean by this? Maybe you should word it that way. And we'll be able to get that input to make it as collaborative as possible. So the first technique that we're going to go over, for example, is muscle energy. Direct and indirect would be how most of us learned it. So I was initially a little thrown by the osseous, non-osseous in the mind map, but that kind of helps us relate better to the other professions who don't use direct and indirect to categorize their techniques the way we do. So knowing that this is a direct technique, you're going into the restrictive barrier as your setup. And then the patient is asked to provide some type of a muscle contraction while held in that position against the barrier. G, would you be able to scroll down a little bit? Thank you. Up a little bit less. Keep going. Up. Perfect. So on each of those, then we break it down into how the technique is performed. So this is just the simple steps of muscle energy, the way most of us learned it in medical school. Going to the new barrier, having a compressive force, waiting a few moments and then going to a new barrier and repeating that process. And then kind of breaks it down. You keep scrolling down to types of muscle contraction. So we break it down and which way you're pushing, whether it's isometric, isotonic, isolytic, and other types of muscle energy that we do, including respiratory assist. You can go down. Using the oculocephalogyric reflex when treating like the OA and the upper cervicals. And then we go into the proposed mechanisms. So that's good. So biomechanical, just simply moving that joint, maybe that C-spine is side bent right, rotated right, and you're bringing it to that left side bending because that's where it doesn't want to go, and applying some type of a compressive force to realign that biomechanically. With regard to the neurological basis, in a post-isometric relaxation, you're going to get that reflex from stretching and be able to engage a new barrier when that muscle is in its refractory state. You can keep going down, or is that the end? No, that's not the end. And then our references. So I don't want to read to you because that's no fun. So I'd like people to say, this is how I understand muscle energy, or, well, you know, I look at muscle energy a little bit differently. Oh, Amy.
Hi, I don't know if this is important, but like we always learned, and when I teach the residents in my program, we talk about the feather edge of the barrier just to give people an idea of how much kind of fine tuning we're using, you know, and that we're really trying to set up the restriction, you know, in the 3 planes of motion. And I don't, you know, for the spinal, and I don't know how specific we need to get, but that we're really trying to localize down to that restricted facet, or that joint restriction. And then at least with I'm from Michigan, so the Michigan state model, there are different amounts of force that are used depending on what you're trying to accomplish. So, but I don't know if those are the kinds of things that would be appropriate for this or not.
I have a comment on that then. One is, I think the concept of localization as a whole is important to the osteopathic profession particularly, and we do have a document somewhere that describes what is our scope of practice in different places in the world, and like what is our general approach. And I think localization is included, or should be included in that, because we would include it in every single technique, because you're absolutely correct that that's so important. What you're saying about how much force to use on and why to use how much force when is probably something we would want to add on. So great. Thanks. Sorry, Crystal.
No, I appreciate your response. I saw you had your hand, so I kind of just kept my mouth shut on purpose. One thing that Amy brought up that I actually do think is unique to muscle energy that we may have overlooked is the feather edge. And I teach at a DO school, and that is something that we do emphasize when we're teaching. And could you scroll back up, G? Sorry. I think we may have actually completely overlooked it. Keep going up, up, up. A little more. Okay, that's good. Yeah. G, while you're in that document, could you put a little comment for us to add an element of that? Thank you, Amy. Just add feather edge. I don't know what that means. I see 2 hands raised, one from David and one from Brian. Who wants to go first?
Go ahead.
I was just going to say the feather edge had been brought up early in the document, but once again, the issue is that something that's going to be easily translatable to other professions' language, and so it ended up you know, once again, trying to be as quantitative at that. I mean, we all have a sense of what that means as DOs, so forth, and how we engage the barrier may be something that's unique about our approach versus another person's approach. And so it did end up getting kind of lost in order to, once again, just to make sure that what was said was as clear as possible. But we'll reevaluate that with that in mind again. So thanks, Amy.
I do like that it says point of initial resistance. And I was wondering if maybe it just in parentheses after that, we put feather edge. So within our profession, those of us who use that terminology kind of, okay, get what's going on. But point of initial resistance, at least in my mind, captures what the feather edge or restrictive barrier would be.
That's exactly what had happened, Crystal. Thank you.
David.
Yeah, I was just wondering about if there should be you got a label for indication for use of the technique. Not in Canada, we use muscle energy as to treat muscles, but also as a preparatory technique. And depending on whether or not depending on the rigidity of the joint lesion, we often use muscle energy as a prep. You can use it as a direct treatment for muscles, but also as a prep for osteoarticular techniques, things like that. I don't know if that's important.
When you say prep, osteoarticular, is that referring to like what we call HPLA in the States?
Yeah.
Okay, thank you.
Yeah.
Other comments and thoughts on muscle energy? I really like the feedback that we've been getting.
So, David, your comment does apply directly to muscle energy because it is listed in the mind map as both having an osteoarticular component as well as a soft tissue component. So
Okay.
it is acknowledged in both pieces of the mind map.
Okay, perfect.
More on muscle energy, or would we like to move on to counter strain? Oh, I see a comment in the chat. I'm not familiar. I'm familiar with functional, but Johnston's functional. Could you elaborate on that? I'm not familiar with that.
Yeah, at least in Michigan, we had Ed Stiles, who has a type of functional technique, and maybe Brian can speak to this more, but William Johnston from Michigan State has a very specific type of functional technique where you're localizing in 7 or 6 different planes, and then you're using the breath too, which it's an indirect technique. But muscle energy can be used to set that up. And it's kind of the opposite of muscle energy. It's a little different than BLT. It's for kind of like an indirect articulatory technique. But I think it's kind of getting lost, which is unfortunate because it's so effective, especially in hospital and acutely ill patients.
Yeah, thank you for bringing that up, Amy. So having worked directly with Bill Johnston and so forth, and had a chance to appreciate that work, we do know, not only within the US, but across the world, a lot of times we kind of slice and dice, you know, various approaches, techniques, relabel, you know, give some slight nuances here and there. And our end goal with ICMT is to develop language that really focuses on quantifying and characterizing the direction of the force, the amount of the force. So it's not, you know, because if you say, well, I'm doing Johnston's functional technique, we still, I mean, there's a lot of nuances to what that might be. And as Patrick had said, you know, if you say, well, I did cranial, well, was it on an articulation? Was it more, you know, balanced, you know, ligamentous tension, disengagement versus, you know, working on a fluid level or a membranous level? So there's a lot of imprecision in the language that we use, that if we can develop descriptors of what is it that's going on, what part of my hand am I using? How much force is being applied in what direction? Then all of a sudden we have a language that everybody's going to understand, no matter what field they're in, whether they're a basic scientist or a clinician. We're going to be able to understand and learn and study what we're doing much better. Okay. Okay, back to you, Crystal.
All right. Are we ready to move on to counter strain? So starting out with direct, indirect, counter strain, as we know, indirect. Another distinction, but difference between muscle energy counter strain, active for muscle energy versus passive for counter strain, meaning whether the patient's moving his or her own body or whether the physician is moving the patient's body. Counter strain is a technique, an indirect technique in which we find a tender point and position the patient to relieve pain at that tender point and hold that position for a designated amount of time. We establish a pain scale to quantify it. Traditionally, it's 90 seconds, although I remember learning 120 seconds when I was in school for ribs, but apparently ribs are now 92. And then we reassess for resolution of the pain at that tender point. An important thing is that tender points are often associated with bony structures or with muscular structures. They could be either. And very often you might find an asymmetry like a Fryette's diagnosis that might resolve after treating its associated tender point with counter strain. So the proposed mechanism for this neurophysiologically would be the gamma gain. We talk about it a little bit in there. Actually, a few different mechanisms. Interstitial fluid, so kind of relieving local congestion at that area for better flow of lymphatics and vasculature. I'll let everyone skim this a little. I think the discussion part is more interesting, but let's see what's there and have a chat. Yeah, if you want to scroll back up to mechanisms, maybe. Thank you.
Yeah, one thing that we didn't go into, but I would really like to hear of your opinion about it. Each technique, pretty much all of them, we can figure it out on the conscious strain because we actively involve patients, asking them if they feel pain rather than not pain. And they feel at the beginning pain and at the end of the technique, not pain in the same zone. So do you all think we should also add a psychosocial effect on the techniques? I mean, feeling pain at the beginning of a technique in a specific point and not feeling pain on the same point after 90 seconds, of course, have some psychosocial impact on the perception of that technique. So do you feel we should add also some proposed mechanism of action which takes in account also the psychosocial effect of techniques, as well of when we talk about HVLA, hearing the pop sound makes some difference from how the patient perceive the effect of the technique, how they rationalize it, for example. So do you think that putting out a psychosocial effect on techniques description might be a thing, or is too non-specific? Actually, we had a discussion about it, and we said that it was not a specific effect of the technique, but rather an unspecific effect of touch in general. So we decided to branch it like this. So I would like to hear also your opinion about it.
I think we also discussed that perhaps in the future we could get in more detail about this level of thing, because it is important and interesting, and like you say, the pop or the scale changing immediately is of great importance to the patient. So I definitely agree that it's worth talking about.
Yeah, if I can give just a little bit more background on that. So most of the evidence right now in regards to manual therapies will say that the mechanisms of action for them, that the current evidence says is primarily a psychological, psychosocial mechanism of action. And there is a lot of literature and review of meta-analyses that have come to that conclusion. Helene Langevin, who is the Center Director for the Center for Complementary and Integrative Health, she had a very, very good article that Amy Dean had presented within the DO Touch Network during their journal club, basically saying that, you know, that conclusion is really short-sighted because we certainly know that there are physical, actual changes going on beyond just a psychosocial level. And so we decided that for this meeting, we were going to stay focused on the non-psychosocial components, the actual physical interaction that goes on with touch versus those secondary and tertiary parts of what we know certainly is therapeutic. And we were looking at that being our primary focus for our second conference, because there is enough literature out there for us to study that issue in and of itself. But we know that what we do with our hands is not irrelevant. We know that there are direct impacts to what we do with our hands on the tissues. So we wanted to separate out those two pieces in our initial work. Build the language, build open collaboration, build trust between the siloed professions. And then in our second meeting, let's look and delve into the current literature about the psychosocial sides of manual therapies. And then we're looking at our third conference where we just really gather around tables and we really look at that palpatory phenomenon that's going on. But by then we have a language that we can work around. We're going to be able to communicate. We're going to be able to actually share in what that experience of what our hands is doing and what the patient is experiencing, all within that scenario. So that's kind of the vision of where we're hoping ICMT goes over the next 3-5 years or so. This is just the foundation of, once again, let us be able to understand what we're talking about. Let's allow us to begin recording what we do and thinking about what we're doing in ways that other people are going to understand. That's what's so critical about this meeting.
We have comments from Amy and from WJBDO.
I just had a quick question on the counterstrain mechanism of action. I know Paul Rennie, when he's teaching his counterstrain courses lately, he's been talking about the cardiovascular mechanism of action and the therapeutic pulse. And I don't know if there's research to support that. And I didn't know if that'd be another mechanism or not, but just a thought.
I think Brian addressed my question.
Okay. Amy, another very important comment there. Our goal with what we're doing today, and it's the goal in the first 2 days of the conference, is to have the voice of the clinician be heard. And so if there's a common conception that the mechanism of action of what's happening when we use our hands represents what we believe clinically, we want that represented here, because a lot of times it's that clinician voice is not really articulated well within that scientific community. Working group 3, as Patrick had stated earlier, that's another group of people that are solely looking at the evidence, the most recent literature, looking specifically at mechanisms of action in regards to the impact of touch. So they're going to be bringing the latest evidence into this conversation at the conference. So we're going to have both a clear, hopefully, clinician voice, that's what we're trying to do here, a up-to-date evidence-based voice of what we understand and what we don't understand about mechanisms of action. Then we're going to have breakout groups where we come together and really help us as, once again, an entire unit to really understand where our strengths are, where our limitations are, what we need to maybe let go of, because really the modern evidence does not give us any indication that that exists or not. So what you're saying is exactly what we're trying to do here, but we want to capture the clinician's voice through the process that we're talking about today. So if there's a mechanism, a mechanism of action that we think generally is accepted within the clinical body, we want that represented here, okay? I can tell you, just since we're talking about counterstrain, I mean, Dr. Jones, you know, who accidentally came upon the technique, I could give you that story, but I won't. He went up to Dr. Kaur and said, well, what do you think is happening here? And Dr. Kaur said, well, based off of our current understanding of neurophysiologic reflexes, you know, this is the reflex pattern that we think you're resetting as a result of taking it into, you know, a point of balance, of a point of no pain and relaxed tissues. And that's where it stopped. And that's where the clinicians kind of held on as their mechanism of action. And so once again, articulating that, so and hope that as a result, the basic science says, well, we can easily test that in this animal model or this tissue model or whatever. We have electrodes that we can place in to see whether or not those reflexes are actually happening. That's what we're trying to do, is bring forth our clinical perspectives to the table of the basic scientists, to their lab bench, so that they're actually evaluating things that are directly related to the clinician's experience, the patient's experience. Does that help to understand kind of where we're going? Okay.
Great, thank you. And all the comments that are being made now, we will be incorporating into the document. So thank you all for your input. G, can you put? I apologize, my Wi-Fi is not so stable right now. Are y'all able to hear me? Okay, I'm not able to see the screen. There it is. Okay, great. So cranial is interesting for a lot of reasons. We will get into them as we go. So first of all, what we call it is interesting. We used to call it osteopathy in the cranial field, OCF. Since 2010 in America, we adopted the term osteopathic cranial manipulative medicine. Here in Germany, I hear a lot of people say craniosacral therapy when they're talking about cranial osteopathy, and they're not specifically talking about Upledger's work. That terminology has gotten a bit muddy here, so it's important that we are clear about the terminology that we're using just for the name of this technique, first of all. Method-wise, as far as direct and indirect, it can be both. If you have, say, a sutural spread, that's going to be direct, whereas a BMT could perhaps be indirect. And typically these treatments are passive, although there are opportunities, for example, with the jaw, treatment of the jaw, to have active techniques too, but we would classify those directly under muscle MMG. For the definition of the diagnosis and treatment method, we modified quite a bit from the ECOP definition and simplified it to a system of diagnosis and treatment, which consists of balanced ligamentous, balanced membranous, tension, and fluid techniques often using intrinsic movements of the organism known as the PRM. We have come to appreciate that OCMM is an application of OMT to the structures of the cranium that can mostly be categorized under other treatment techniques. Additionally, the application of cranial concepts apply not only just to the cranium, but to the treatment of the rest of the body by engaging the PRM. So as Patrick had alluded to earlier, we can classify some of our treatment methods as more of models of application of other techniques. For example, in the head, we have BMT, balanced membranous tension, which is analogous to BLT, balanced ligamentous tension. However, there are some techniques like V-spread or CB4 that don't have direct analogs elsewhere in the body. And again, in the rest of the body, we can use the PRM or apply some of these cranial concepts throughout. Can you scroll down, please? So we divided our how the technique is performed and further the definition into 3 components: the articular and membranous and fluid diagnoses. Articular diagnoses are going to be those related more to the sutures or the SBS, whereas or a static position, for example, temporal internal rotation preference. Membranous diagnoses are going to be more related to the reciprocal tension membrane or the dura as a whole. And then fluid diagnoses are going to be involved with the fluid dynamics, which would include the palpation of the PRM. Scroll down, please. So then the techniques can often be focused primarily on one of those 3 categories, although we're always affecting all 3. So for example, in BMT, we are really dealing with the membranes, but of course we're dealing with the bony relationships at the same time, and we're using the fluid as a reference point with the activation sometimes. Exaggeration would be more of a bony type technique, disengagement also bony, and then fluid techniques such as V-spread or CB4 are going to be primarily focused on fluid. Sorry, I see some comments. Are these? Oh, yes, great. Okay. Thank you. Yes, so proposed mechanisms of action. So there is a wide variety of research as applies to cranial osteopathy. I was trained in the US and I live now in Germany, and I found an entire breadth of research that was completely unavailable to me in the US because of the language barrier. And so it's been really interesting what is seen here as not having been proven and what's seen in the US as not having been proven, and that we actually both have different types of research supporting different things. So there is quite a bit of research here in Germany about the intrinsic motion of the head, and that there is a separate third respiratory mechanism in the body that is not the same as the pulse or the respiration. So I could get into that more, but I'm not going to right now. So we can break down our mechanisms of action about how we're interacting with them into the articular, membranous, and fluid. Scroll down, please. And our treatment goals as they relate. And keep going. Oh, that was it. Okay, I didn't know if we included in here there the research regarding the intrinsic motion and the basis of our treatment. I think we have that elsewhere. So that is how we have characterized cranial. Are there any questions or comments about this? I'm sorry, which terminology are you referring to, David?
Just all the definitions. Does that already exist in the document that the current working document for the glossary that we're comparing with other professions?
Giacomo, where are you? There.
Yeah, I'm looking for the question. The documentation.
Yeah.
Is that about the documentation goal? No. Okay. As I was reading from the glossary of document. Yeah. The osteopathic one is derived from the osteopathic glossary. Yes, 100%. And the other professions put them themselves And they put a reference on the document they used to take that term from. So some are papers, some are books, whatsoever. It's defined in the document. For the osteopathic profession, we took everything from the Glossary of Osteopathic Terminology, the last edition, which is the one from Rebecca Giusti on 2017.
17, right, exactly. Yeah, we did. I will say, I think we said this already, that we took the ECOP definitions as our basis, but then we did sometimes modify them to make sure they were inclusive of the way it's taught around the world. So some things in America, we tend to be kind of American-centric in our thinking because there are just so darn many of us, and we have so many schools, and we have a system of standardization that other countries don't have the luxury of. So so it's been really interesting for me living overseas and seeing the differences. So I think it's really wonderful. We have Patrick and Giacomo from other countries here as well. So we were able to integrate everyone's understanding and descriptions of things together in over the basis of the ECOP definitions.
So one of the things that Patrick had introduced earlier, and it really comes out of our analysis of the technique descriptions for the various techniques, and also how we would be then collecting that information in an electronic medical record that would be used for looking at effectiveness and patient outcomes regarding, manipulative medicine. A term such as cranial work, is really very non-specific. And maybe we need to look at ways that are more precise in regards to describing what we do, where we do it, and the intention associated with that. So as a transition, I'm going to maybe let Patrick, begin to open up a little bit more of that perspective, because this is something that we're going to talk about in detail at the conference, and once again, to help promote a language that is going to be easily transferable across professions and with basic scientists that really is quantitatively descriptive about what we're doing with our hands and what we're intending to influence. Okay, Patrick, do you have some more comments you'd like to make there?
I can maybe better look at the mind map and guide you through the mind map. So here we have the osteopathic mind map. And in this, we have the cranial, the visceral, and also the facial distortion models. So, and we might want to evaluate, so move towards another kind of mind map, where we see that the cranial, for instance, lends a lot of techniques from who we already described. So for instance, the BLT technique, BMT techniques, also counter-strain techniques, so we can do counter-strain techniques on the cranium as well, and also fluid techniques, and the same for the visceral. So the visceral techniques, it can be BLT techniques or BMT techniques, and also fluid techniques. So all these models, they have their own techniques, their own single techniques already in the list, already in a mind map. And for this, we created also an extra single techniques that we called intrinsic inherent movement techniques, that are also used with cranial techniques and visceral techniques, for instance. And that go back to towards the PRM, for instance, and also embryological movements that we see in visceral techniques. So I think this is our move forward, I think, in the mind map. And eventually we can skip all these models and say, okay, let's look at all the single techniques. And then we can say, okay, for a visceral model or a fascial distortion model or a cranial model, we base our techniques on the techniques that are listed here in this mind map, for instance. Don't know if this was clear, and if you have any other comments or questions about this. Yes, please.
Yeah, go ahead, Bill.
So this is the first time I've been invited to participate with this group, and thank you for inviting me. And I'm just in awe of the ambition that you and Dr. Stanley have for this whole effort. The one thing that strikes me is the absence of the allopathic profession, and it may be that you don't feel that the process is mature enough to invite input from them, and specifically the musculoskeletal community and the allopathic profession, orthopods, rheumatologists, PM&R, neurologists. So I hope that perhaps you're thinking that communicating ultimately with the basic scientists is the bridge to that. But I'm wondering if not having input from that world could be problematic, since this is in a very formative stage. Having that input might be really important. So that's just kind of standing back and looking at everything I've been hearing in the last hour. As you know, Brian, have spent a good portion of my career working in allopathic settings and as a specialist in manipulative medicine. And so that really came front and center in my thinking about this. And I do see changes in that world that potentially are bridges between the whole world of manipulative medicine and that world. So that's just my 2 cents for right now. Thank you.
Yeah, you're absolutely right. We have discussed this as well in our group that, for example, therapies. Oh, everyone froze. Am I still here? Okay, great. Yep. And you're right. Yeah, rheumatology, neurology, and getting all these specialists on board makes a lot of sense. Yeah.
Yeah, just for a little more historical perspective, when we were going to have this as an in-person conference, it was going to be at the University of Arizona School of Medicine. So it's hosted by one of the, certainly a premier MD school, and certainly the invitation out to people such as in physical medicine, rehab, sports medicine that may have incorporated manual skill sets are always encouraged to participate. Just because we have 5 professions that have, engaged in this early stage of the process, we have some occupational therapists who are interested in coming to the meeting, applied kinesiologists. I mean, we are in no way limited in who we are trying to engage in this process, because in the end, if you're using your hands diagnostically and therapeutically, the language that we're constructing, the perspectives that we're going to be sharing are going to be relevant to all of us. So, so if you are aware of people that fall outside of this scope, they're in no way excluded. Please make them aware of what's happening. Certainly invite them to participate in the conference. They will definitely easily find a place for their voice. Okay. So I guess, are we ready to start looking then a little bit more detail about the conference itself? Leah, do you have anything else to cover?
I do not, but I did lose my connection for a second, so I missed the last 60 seconds or so, sorry. But I don't think I have anything to add, nope.
Okay, any final questions before we go into what the program is going to look like in May? Okay, so G, if you wouldn't mind sharing the schedule. I have GatherTown ready to follow with that, but if you can bring up the schedule and share that, that would be excellent. So to say the least, this has been a challenging experience of a grassroots process, because when we started in the summer of 2019, we had 6 months of work before the pandemic started, with the goal that our conference was going to be at the University of Arizona in May of 2021. And the pandemic basically just shut that down. So we decided that we were going to delay it a year, hoping that the pandemic was going to work itself out. In December, as Omicron was rapidly spreading across the planet, NIH went to purely virtual activities again. The University of Arizona was debating whether they were only going to go into remote training of their students, and if that was to happen, they were not going to host an external group coming in. Issues of travel, and certainly that continues to be an issue across the world. We made a shift to make this a live online type of activity. And in the process of doing that, we became aware of a platform called GatherTown, which has allowed us to really think out of the box about what can we do to make this conference so much better than if we had just done an in-person conference. And so we, through GatherTown, which we'll show you in a minute, it allows us to have 30 days of community building, which will begin on May 4th and will wrap up on June 3rd. What we decided, because of being online and because we've all been doing that, like today, through Zoom, conferencing, webinar, so forth, that they're not always the easiest way to stay engaged in a educational program. And so GatherTown is going to allow us to have a much more dynamic, interactive, and fun environment, which we'll show you in a minute. And what we've done is we've taken our program and split it up in a way that we think is going to really make it easy for people to make this part of their experience in May. So we have, in the very beginning, we're going to have a certain amount of tours and training for people just to get used to the GatherTown experience. And so you'll have the ability to view a video to get some initial orientation, and then we will have docents to take you around the conference facility, train you how to interact with other people at the meeting. We'll have our welcome reception on May 5th. We've scheduled it so most of the time in the US, it's going to be in the morning to early afternoon hours. So in the European time zone, it's going to be in the later afternoon and evening hours. We've tried to keep the content to be about 5 hours a day over a 6-hour period of time, so that there's plenty of breaks for discussion and meetings and meeting with sponsors, just like it would be if you were at a conference site. And you'll see that in a moment. So our first day is really specifically looking at what we've gone over today, purely within an osteopathic arena, but doing it across the different professions. We have a keynote speaker, Dr. Lars Arndt Nielsen, who is world-renowned medical doctor, PhD researcher in the area of musculoskeletal pain. And he was the president of the International Association for the Study of Pain when we first began planning this 2.5 years ago. He has over 900 articles written about pain and the characterization and quantification of pain and the response of people in pain to various types of inputs and so forth. So he himself has been a bridge from the clinical world, from patients in pain to the basic science world of really trying to describe it, and has led the premier global organization that is multidisciplinary, interdisciplinary in regards to pain, both from a clinician, a social science perspective, and so forth. So he's going to give our opening keynote presentation about why it is so important to look at sustaining collaboration and stepping outside of silos to advance science and patient care. And then what we did today, we will then have an overview of how we looked at defining manual therapy procedures. We go into breakout sessions, so that allows everyone that is participating to have a voice to give some critique and dialogue on the information that's being presented. We're going to have our first breakout session, which will be the only breakout session that will be profession specific, just to make sure that everybody is able to be on the same page within their own domain. Now, I can say that we, over the last 40 years, have done a lot to help to unify nomenclature, to build a construct for education in our field. But we still know there's a lot of diversity in language and in opinions about certain things. I can say when we look at other professions, they have not evolved as far along as we have. And so they're having to fast track some of their members to really look at issues of nomenclature and so forth. And so all of that is going to be a really mind-opening opportunity for us to be able to learn what other people think, to learn about what they do with their hands, so that when we look at the literature, when we look at the science that has been done, we know how it applies to us. I can tell you, having done this for 30 years, you know, what I have seen done, that when people read the literature, and if by chance, let's just take an example of high velocity, low amplitude technique. If the study was positive, they would end up saying, oh yeah, that's what we do, even though it might have been done by the chiropractic profession. But if it was a negative outcome, they say, oh, well, that's really not how we do it, but we really don't know what was done and how it was done and so forth. So there's just so much ambiguity within our language that we don't even know how to interpret the science being done. So once again, that's why it's so important for us to be doing this. So day one is solely looking at nomenclature related issues through our various breakout sessions and our discussion sessions. For day two, we then go to looking at mechanisms of action. What are the physiological theories that we feel occur that underlie the work that we do with our hands? And so the outer rings of the mind map is that particular part of this program, and really starting to dialogue about an understanding between professions. What are the physiologic theories that we use when we do various types of techniques? I think we're going to find on some levels that we're way more similar than we might have ever thought, but there will be nuances that I think will be intriguing across the various professions. Okay, so that's the first 2 days of our meeting. One will be on a Friday, the other on a Saturday. Any questions about those two? Okay. So day 3 and day 4 are the components of the meeting that's really the science evidence-based part of the program. This is coming from working group 3, which are the clinician scientists and basic scientists who've been reviewing the literature to pull out our best understanding of what we know goes on when we place our hands on the human body. They've been able to kind of hone in that evidence into 3 different topic areas. And I'll just give examples of the terms at this time: biomechanical influences, neurophysiologic influences, and biologic influences, which would include fluid, lymphatic, biomarker type of research. And so we're going to get the latest information on those 3 general areas at the, in this morning's, in this day 3 session. And then we're going to go to breakout rooms and an interprofessional process, critically discuss what does it show, what does it mean, what does it not show, what do we still need to work on and do research, and really help to create a platform that will prioritize what we hope will be, the future directions for research. In the following day, we have our poster session of the latest work that's occurring within the field. I can tell you that, so currently abstracts are still able to be submitted up to March 1. So please communicate with anyone that is doing work in this area, that this is a great environment for them to present their work. I can tell you, looking at the scope of work that has been submitted, that this is really groundbreaking work about really the specifics of manual techniques and so forth. And so we will have that. We'll have a break, and then our final keynote speaker will be Helene Langevin from NIH, talking about lessons learned from and the future directions for manual therapy research. If you have not read her recent articles, you really need to. Amy, you can go to YouTube to look at Amy's review for one of our journal clubs for DO TouchNet, our practice-based research network, to really see just how far NIH has come in understanding where the hands really fit within the medical paradigm. Her language is so osteopathic, it was really amazing to me. So she will be our final speaker for our defined program. And then we'll have a chance to have greater discussion on that after that, and where do we go as a consortium from there. Jeff did have just posted an ability to connect into that article and Amy's presentation for that. And then we wrap up the month with our closing ceremony on June 3rd. And you may wonder, well, why is that even necessary? Okay, so I'm going to now go into the conference site so you can better understand what this is going to look like. Okay, so this is, are you seeing the initial screen together, Town? Okay, all right, so the first thing you do is you end up creating your image. And so this is my current look for Saturday today, and I'll be joining GatherTown, which will take me into a large conference center. And so right now, I'm going to walk on down. So here you can see we have a lot of breakout rooms where we'll be having our interprofessional discussions. You'll go in there, be able to take your seat. You can, we'll be able to pull up a board that we will help to kind of be our whiteboard for capturing the discussions that we would be having during that breakout room, and then would be presented at our report times in the auditorium. We're heading now into our sponsor and exhibitor area. And so here are some of our sponsors. We have the Ida Rolf Institute, the Ida Rolf Research Foundation. This is our primary area for question and answers, where Jeff is here, who will make sure that everything runs, perfectly, and that all your answers are addressed. Questions are addressed whenever it's necessary. You head down here, and here's one of our sponsors, DO TouchNet, which is a DO practice-based research network. You can go up and look at what's on their table, and this is part of their swag drawing in their guest book, so you can let them know that you were there, and go over to the next one and pull up another screen, and this will tells you about how to become a member, what this membership is all about. And there'll be people live in those chairs behind the table to answer specific questions. And so that will happen across with all the different sponsors and exhibitors. We head down into the auditorium area, and you can walk into a lecture hall and take your seat, and you can wait, and the presenter will, the moderator will come up and will be addressing the audience, and will pull up, a full screen slides and image, and a live image, an in-person image of the presenter for the actual keynote presentations. So once again, like a typical conference area, you will need to be kind of moving around and going from different locations. So now we're going to head over to where the poster hall is, where our social rooms are. And in the poster hall, one of our major sponsors will have a table here for people to get more information. You can walk up to these kiosks, and at the kiosk you can open up a list that will have all the names of the various posters that are being presented, the actual presenters and the research team. Right now, this just goes to the place for registering to be able to have your abstracts reviewed. You can go down, and so at area 2, you walk into the area for that particular poster. There will be a kiosk where there will be a 1-minute video clip done by the presenting author to give background about the research and why this research is important. You can then walk up to the actual poster and take a look at that, and look at that. When it comes to the actual poster session, the poster presenter will be here. Anyone within that light brown area will be able to listen to that. So up to 25 people, I believe, will fit in that box as the actual formal presentations occurring. We have some fun things. This is a lot of this is still work in progress, but we have a corn maze here that if Jeff and I can have our own little race as to how who's going to determine. And right now, I think he might be, no, he's on his own. Okay. So anyway, this gives, maybe I can lock him in here if I get out before he does. So a little ability to have a little fun. We can go across to this other area, and this is also going to be kind of a more of a social area. Here, we have different breakout areas where you can just sit down and have a conversation with people. There'll be some areas that will have a game. What we are doing, it's not currently built, or we haven't paid the rent for that space yet, is we're going to hopefully have in here in a cinema where we're going to have videos where you can go in, and one of the programs will be, you know, videos of techniques. And we're going to have video clips that are maybe 2-3 minutes long of how an osteopathic physician does a high velocity, low amplitude technique to a lumbar spine, thoracic, cervical spine. And we're going to have that done from a physical therapist perspective and from a chiropractic perspective. So we actually can gain some really insightful visual information about how similar or how different we are in regards to when we use the different language we use when it comes to patient care, just how similar or how different it is. Now, this cinema, we're going to hopefully have a program that will have historic videos of, you know, Dr. Still, Ida Rolf, different, you know, early key people within the various professions. So we can get to know each other about our histories a little better. And we have a panel that's going to put together a program discussing, you know, the nuances of the history and how we evolved as different professions. So we have representatives from each of the professions that are in the process of gathering around that time. This information, the cinema, these videos, they're going to be available 24 hours, 7 days a week during that month. So you can come in and let's say, well, you know, I really like that initial presentation. I want to watch it again because I'm not sure, you know, that I captured everything that occurred. One of the challenges at a regular a historical meeting is that you'd go and you'd watch a presentation, you'd say, wow, this was great stuff. You travel home and all of a sudden it's like, now what did they say? And you try to open up your notes and it's like, well, I'm not sure I really am appreciating it as well as I did when I was listening to it. With this format, you can go and you can watch it over and over again during that month to once again get the most out of what's being presented. And then we also have, because a lot of conference areas, you know, we at a live in-person conference, sometimes you just need to get out of the lecture hall and you need to spend some time just relaxing, doing some friends. We are building out a park area where you'll be able to go up to, first of all, you can sit and have a chat with friends, or there's going to be places where you can go up and launch a video that would be for stretching within your office, a 5-minute stretching routine, a 5-minute kind of meditational routine, a 5-minute qigong routine to help re-energize, a 5-minute, you know, movement, more activity, you know, aerobic type of thing. There may be others areas. Right now, one that I'm working in my own mind is one that will talk a little bit about science and spirituality. How do those, because people in hands-on work typically have a better appreciation that there is a continuum of what they're working on and actually have, you know, some scientific perspectives about, you know, the spiritual side of the human nature. And so any of this type of programming can be very spontaneous. It can be done by anyone. And so if all of a sudden, you know, you watch a lecture and it's like, wow, I really want to discuss this about, you know, the mechanisms associated for high velocity, low amplitude technique, we're going to have a calendar where you can say, well, at 7 p.m. this time, in breakout room 1. For those that are interested, you can come and we're going to discuss more about this issue or that issue. And so it becomes a very spontaneous, dynamic, interactive program throughout the whole month of May across the various professions. So this is the vision that we have for our inaugural conference for ICMT. I hope you can see that by design, that this is unique. This is revolutionary on many levels, from an education perspective, from an interprofessional communication level as well. So with that, we're back into our informational desk of our conference center. Are there any questions that anybody might have that we need to discuss further? Okay, I'm going to stop sharing then, if nobody else needs to see anything with GatherTown. Any questions, comments, concerns?
I have a really tiny question. I just want to make sure I heard you right. When you were talking about the replays of presentations, does that include the keynote speakers and such? Okay, wonderful, great.
David.
Yeah, that's a similar comment. So how long will that be available for? Let's say you can only make the first weekend or you're going on a vacation or something.
Right.
How long will it be available again?
Through June 3rd.
Okay.
So from May 4th to June 3rd, whatever is there is you will have access to basically 24 hours, 7 days a week.
Great. Thank you.
And so, you know, you could, once again, you say, well, hey, Brian, let's meet up. I'm going to be out of town for this day. I'd like to hear your opinions about this talk. Well, let's meet, you know, in GatherTown, and we'll, you know, it can be a gathering opportunity at any time around the world. Okay. All right. Well, we certainly want to appreciate, thank you all, give you our appreciation for your attendance today. We hope that what you have seen, you see as something that is unique, that is something that's important, that is something that is deserving of your time and effort. We hope that you're going to be willing to share this information to the people you know, because the more people we engage, the more we are going to be able to meet our mission, to break down barriers, to improve the science and the patient care associated with manual therapies. I think this is something that we have known needed to occur for a long time. This is not a novel idea, but the fact that we have taken the initiative to do the work up front in preparation for it versus to have a meeting and say, well, we're going to do it, but we never do it after the meeting because we can't pull people together. We have a strong foundation to build this consortium. You will see that. You've seen that to a certain level today. You will see it in its full manner at the conference from May 4th to June 3rd. Questions? Okay, so if you are on social media, certainly please like us. Please help your friends to be aware of what we're doing through connecting things along that line. And if people have, there's one more thing I do, because many of us are in educational programs. We have made an opportunity for having an educational registration. And what that involves is that a teacher with up to 9 students can register as a group. and that will be a 75% discount to be part of this meeting. What's going to be, if you want to have your own avatar and independence, then it's just under $400 for that cost. But for a group, an educational institutional group rate for under $1,000 for 10 people, you can participate. And that what that means is that your group would get together in the same room. You would function as a single avatar. You can walk up to, you know, the leaders of whatever profession and open up your camera, and as a group interact with Dr. Langevin, with Dr. Arndt Nielsen, with all the other leaders across the professions. And then you can also have, you know, just within your own group, some dynamic discussions while things are going on. So we're hoping that this will be seen as a way to really, and then for those in the international community, this would also allow for translation to occur to a larger group. So if, you know, if you have a group of people that are not as facile with the English language, this will allow you to easily get things translated to your student body, to your group. So certainly know that this is a unique option for this conference as well. All right, well, thank you all. We certainly look forward to having catch up with you during the conference. If you have interest in getting involved prior to then, certainly let us know. There are ways to certainly help as we prepare the final stages for the conference. So thank you for your time. Have a great weekend, and we look forward to talking with you soon.